Hello everyone, welcome. I am Dr. Sharif Al Halim and today I am going to talk about Cushing syndrome. So before going to the syndrome itself, let's just first talk about cortisol. So cortisol is a very important hormone in our body, also known as the stress hormone, which is secreted from the zona fasciculata or the middle layer of the adrenal cortex. And in the circulation, it is bound to the corticosteroid binding globulin. And it is the free cortisol which is responsible for all the actions of the cortisol, including the negative feedback mechanism. Cortisol has multiple functions in the body, and there it actually stimulates some activity or increases some of the functions of the body and decreases some of the responses of the body. The functions that are increases, those are increased blood pressure, increased resistance to insulin, and increased gluconeogenesis, lipolysis, and proteolysis. The mechanism by which increased blood pressure occurs is like this. Cortisol increases the number of alpha-1 receptors on arterioles. Arterioles are actually the main set of blood pressure, which actually controls the blood pressure mainly. And if there is increased number of alpha receptors, now you have a more sensitivity of blood vessels to norepinephrine and epinephrine. So the same level of norepinephrine and epinephrine will produce more effect in the presence of cortisol. So this is called a permissive effect. This is very important in shock states. And at high concentration, cortisol can also bind to mineralocorticoid receptors like aldosterone receptors. So at high concentration, cortisol can also actually retain the salt and water, increase plasma volume, and ultimately increase blood pressure. And cortisol, as I've already mentioned, it increases insulin resistance, so it is diabetogenic, meaning it increases the blood sugar. And it also increases blood sugar by increasing gluconeogenesis. The way cortisol increases gluconeogenesis is it actually increases the synthesis of the enzyme that are responsible for gluconeogenesis. And it also increases lipolysis, releasing fat, and also it increases proteolysis, especially from the muscles. So you can see here there are two distinct types of action on protein metabolism. Like in the muscle, it causes proteolysis. In the liver, it causes synthesis of protein enzymes. So it's kind of a two-phased hormone. The responses in the body which are decreased by cortisol are decreasing fibroblast activity, decreasing inflammatory and immune response, and decreasing bone formation. And if someone has a decreased fibroblast activity, there will be thinning of his or her skin, because fibroblast is responsible for a deposition of collagen on your skin, and collagen is one of the main strengthening substance of your skin. So if your skin gets thinner and weaker, it cannot take as much resistance as it should. So one of the resistance areas in your body is abdomen. So inside the abdominal organs, there is increased pressure of the abdomen, which actually exerts the pressure on the abdominal wall and ultimately on the skin. So if the pressure of this abdominal skin is put on a thinner skin which is weaker, it will lead to formation of stria. And one of the very important effects of cortisol are decreasing inflammatory and immune responses. This is very important. Those are the most important reasons for using cortisols as a drug. And cortisol does this by multiple mechanisms, and one very important part is inhibition of production of leukotrienes and prostaglandins. So those are the most important inflammatory mediators, also known as arachidonic acid derivatives. So those are actually synthesized from your cell membrane. So your cell membrane contains phospholipid, and those phospholipids are then broken down by an enzyme called phospholipase A2 to produce an important fatty acid called arachidonic acid, which ultimately gives rise to leukotrienes and prostaglandins. Cortisol does inhibit the phospholipase A2. So as the phospholipase A2 is inhibited, you will not have much amount of arachidonic acid, and ultimately the level of leukotrienes and prostaglandins will go down. Cortisol also inhibits WBC adhesion on the endothelial surface. So as you may remember, that many of your neutrophils are actually attached on the surface of the endothelial cells. They are not actively circulating, and it actually helps you to transport your neutrophils from the vessel up to the outer areas of inflammation where you need the neutrophils. But whenever someone gets a shot of cortisol or glucocorticoids, the WBC adhesion capacity actually decreases very rapidly, and that's why the neutrophils which were adherent to the endothelium now comes back to the circulation again, and it might lead to neutrophilia, which is transient. And transient neutrophilia may be clinically manifested as increased temperature and chills. Cortisol also blocks the release of histamine from the mast cells, reduces the level of eosinophils, and blocks production of interleukin 2. It becomes very important in the long run, because if someone gets a very high dose of steroid for a longer period, interleukin 2 might lead to severe immunosuppression, causing reactivation of tuberculosis or candidiasis. Cortisols also decrease bone formation by decreasing activity of the osteoblast. So you can remember the action of the cortisol by the mnemonic big fib. So big fib means those three actions are increase, those three are decrease. B for blood pressure, I for insulin resistance, and G for gluconeogenesis. And in the fib, F for fibroblast activity, I for immune response and inflammation, B for bone formation. All are decreased. So regulation of cortisol is very important to know. So it's regulated by hypothalamic pituitary system, and hypothalamus releases corticotropin releasing hormone, which stimulates the release of adrenocorticotrophic hormone from the pituitary gland, which ultimately increases the production of cortisol from adrenal zona fasciculata. If someone has an excess cortisol, which will lead to feedback inhibition of the corticotropin releasing hormone, leading to inhibition of release of adrenocorticotrophic hormone, and ultimately reduction of cortisol secretion. And if some patient have a chronic stress, he or she might develop a prolonged secretion of the cortisols. And now comes the disease, which is Cushing syndrome. So Cushing syndrome is a disease or a syndrome which occurs due to excess level of cortisol in your body due to any reason. So one of the most common reason nowadays is exogenous corticosteroids. You see, corticosteroids are used for many diseases, like many inflammatory diseases and many allergic diseases, as a very common drug, and also rheumatic diseases. Any type of rheumatic diseases, ultimate resort is corticosteroids. So it's very commonly used, and sometimes the patient can use it for a longer duration. And whenever patient have a level of corticosteroid, high level of corticosteroid for a longer duration, it will have the detrimental effect of the steroids on your body, leading to Cushing syndrome. And as the steroid is exogenous and is high, it will result in decreased level of ACTH due to feedback inhibition. And ACTH, as ACTH is responsible for maintaining the growth in the cortex of your adrenal gland, as if the ACTH is decreased, it will result in bilateral adrenal atrophy. So it's very important to remember, someone who gets a large amount of steroids for a long period, he or she might be at danger of adrenal crisis at any time, because the patient develops bilateral adrenal atrophy, because the adrenal glands are a bit, what should I say, they are lazy, they are not active. That's why they become atrophied, and also the response from ACTH is not there, so they become atrophied. And if the patient somehow needs a higher dose of steroid, they cannot produce it themselves. So suppose some patient is getting a surgery. So whenever someone is getting a surgery is a very high stress, leads to it needs a very high amount of steroid to sustain the homeostasis, and the patient needs a bigger dose of steroid. So if someone does not increase the dose of steroids in this kind of stress patients, this might lead to acute adrenal crisis. Very important to remember. And one of the another causes of Cushing syndrome is primary adrenal adenoma, or hyperplasia or carcinoma, leading to increased secretion of cortisol from the adrenal gland. It also results in decreased ACTH, and the uninvolved adrenal gland will become atrophied due to decreased trophic secretion or decreased trophic stimulation of the adrenocorticotrophic hormone. And these patients also can present with pseudo hyperaldosteronism. And one of the other important causes is ACTH secreting pituitary adenoma. So this is a less common type of pituitary adenoma. The most common of pituitary adenoma is prolactinoma, as you might already know. ACTH secreting pituitary adenoma is a classic one which causes the Cushing disease, actually described by the Harvey Cushing, the pioneer of the modern neurosurgeon. And Cushing disease is responsible for the majority of endogenous causes of Cushing syndrome. So actually Cushing disease is more common than adrenal hyperplasia or adenoma. And paraneoplastic ACTH secretion is one of the less common of the Cushing syndrome causes. This might occur in the situations like lung cancer. So lung cancer patient can actually secrete some ACTH-like substance from their cancer cell, and those ACTH-like substance will have the actions of ACTH on the body and ultimately lead to bilateral adrenal hyperplasia and increased secretion of cortisol. So the cortisol level will increase and ultimately leads to Cushing syndrome features. So those are the causes of Cushing syndrome. Now let's come to the clinical features. So clinical features, actually you can integrate the clinical features based on the functions of the cortisol. Very easy to integrate. So you see, one of the many features is hypertension. So as I have already mentioned, cortisol have a pervasive action, especially on the arteriolar alpha-1 receptors. They upregulate the receptor, so increases the sensitivity of the receptors to epinephrine and norepinephrine, leading to increased blood pressure, and also it has an aldosterone-like activity in high doses, leading to volume retention. And cortisol decreases the osteoblast activity, leading to osteoporosis, causes immunosuppression by multiple mechanisms, and might cause amenorrhea. And one of the very important feature of Cushing syndrome is muscle weakness with thin extremities, especially the weakness in the proximal region or proximal myopathy. It occurs as the cortisol breaks down muscle for gluconeogenesis. You see, cortisol is a two-phased hormone which breaks down muscle and produces enzymes for gluconeogenesis in the liver. So it's kind of a two-phased hormone. And one of the important features of cortisol was it increases the resistance of insulin. So there will be high level of glucose, and high level of glucose will actually result in high level of insulin, because if there is insulin resistance, body will try to cover it up by increasing the synthesis of insulin, and increased insulin level will lead to deposition of fat in the multiple parts of your body. And one of the region where it deposits is face, leading to moon faces, on the neck leading to buffalo bump or buffalo hump, and truncal obesity. And another important feature is abdominal stria. This occurs because, as you know, that your skin needs collagen for the strength, and that in case of high cortisol level, there is impaired action of fibroblasts, so there will be decreased synthesis of collagen, leading to thinning of skin, ultimately formation of stria. So here you can see a patient with truncal obesity and the abdominal stria hair. Those occur due to decreased fibroblast activity. So the thinning of skin can lead to some other features too, like the patient can get a rash, ecchymosis, easy bruising, even delayed wound healing, not only due to decreased collagen synthesis, but also as the patient has a decreased or reduced inflammatory response. Okay, so next is diagnosis. So diagnosis of Cushing syndrome actually includes some screening tests and some confirmatory tests. So screening tests are multiple, and one of them very important or very common screening test is measuring your 24-hour cortisol level in the urine. So it's a good measurement because your cortisol level is actually goes up and down in multiple times in the day, because it has the circadian rhythm. And that's why measuring the free cortisol level on the urine on a 24-hour urine sample is a very good test. Another important test is overnight low-dose dexamethasone suppression test, which will show that the cortisol is not suppressed by a low-dose dexamethasone suppression test, but it is not that much of a valuable test. But one of the most valuable tests is measuring serum acetate. So this is the most important test, very important to remember. So if the serum acetate or adrenocorticotropic hormone level is decreased, you have to suspect adrenal tumor or exogenous adrenal hormone supplementation, like exogenous steroid intake. So if someone has an adrenal hormone or exogenous intake of steroid, it will lead to inhibition of release of CRH or corticotropin releasing hormone, and also inhibition of secretion of ACTH. And if the serum ACTH is increased, you have to suspect that this patient might have an pituitary adenoma which secretes ACTH, or might have a problem with the lungs, like the lung cancer releasing ectopic ACTH. So you have to differentiate between two if you get a high ACTH. And the way you can differentiate is by high dose or 8 mg dexamethasone suppression test. And also you can do it by corticotropin releasing hormone suppression stimulation test. And one very important point to remember is, as the ectopic hormone is not under the control of CRH and is not under a normal circumstance, it is an abnormal situation, the ectopic secretion will not decrease with dexamethasone, but the normal secretion from the pituitary adenoma will decrease on a dexamethasone suppression test, because it's a normal physiology. And ectopic secretion will not increase with CRH or corticotropin releasing hormone, because you have actually pituitary ACTH which is already suppressed by high level of cortisol stimulated by the ectopic ACTH. So a bit busy. I have a slide for you to show this again to review. So one of the best method to diagnose, the basic algorithm of diagnosis, is through measuring ACTH. So this is the best method. So measure ACTH. If you have a low level of ACTH, you will have an ACTH independent Cushing syndrome, which might be due to exogenous steroid intake, or might be due to an adenoma in the adrenal gland. So you might want to do an MRI to confirm adrenal tumor and take a good history of the patient. And if the ACTH level is elevated, now you're having an ACTH dependent Cushing syndrome. So ACTH dependent Cushing syndrome might be due to a pituitary adenoma secreting excessive amount of ACTH, or might be due to an ectopic secretion of ACTH from the lung cancer. So what you do now, you do high dose dexamethasone suppression test. And whenever you do a high dose dexamethasone suppression test, it will inhibit the secretion of ACTH from the normal source, which is the pituitary gland. So there will be adequate suppression in Cushing disease, but there will not be any suppression in case of ACTH secretion. Very important to know. You can also do a CRH stimulation test or corticotropin releasing hormone stimulation test. So as the corticotropin releasing hormone normally stimulates the pituitary gland, if someone has a pituitary adenoma, he will have a response to CRH, and CRH will cause an increase in level of ACTH and cortisol, meaning the patient has a Cushing disease. If the patient does not respond to CRH, the patient does not have an increase in ACTH, does not have an increase in cortisol, he or she might have an ectopic ACTH secretion. So this is the basic algorithm for diagnosis of the Cushing syndrome. Thanks for watching my video, and please wait for me and pray for me too.